in the Facebook group, and I'm really excited to welcome Dr. Horowitz to be with us here today. He's treated over 12,000 chronic Lyme disease patients over the past 30 years. His new book, How Can I Get Better? An Action Plan for Treating Resistant Lyme and Chronic Diseases, went on sale last month. If you don't already have a copy, there's a link above this video where you can go through to purchase it. The book contains brand new research on Lyme diagnostics and treatment, emerging Borrelia species and co-infections, exciting data on pulsing and persister protocols with important scientific updates on the 16-point MSIDS map that impacts your health. Thank you so much, Dr. Horowitz, for joining us for the next hour and a half. Our members are really looking forward to hearing from you. We've been having excited messages all week. And while we wait for the first question to come in, can I please ask you to start by commenting on the new persister protocols covered in your book? If you could just summarise the research and the implications for treating Lyme disease and co-infections that you've come up with since the previous book, please.
Right. So, in the first book that I wrote, Why Can't I Get Better? I would say probably 90 or 92% of the people were getting better with the protocols, but probably about 8% of the people, no matter what I did, I couldn't get them better. And then after the first book got published, there was research that came out of Johns Hopkins University from Dr. Ying Zhang. There was research from Northeastern University, Dr. Kim Lewis, and then research on biofilms that's come out from Dr. Alan McDonald, Dr. Eva Shoppe from the University of New Haven. And what we found with this new research is from Hopkins and Kim Lewis is that Lyme is what's being classified as a persister bacteria. Now, we've all kind of known that Lyme can persist in the body despite some physicians who do not believe it. There are numerous articles that basically confirm this. But what it meant for me when I saw that it was a persister bacteria is I went to the medical literature and I looked up to see, well, what are the other persister bacteria that make people sick? And the two top ones, of course, that caught my eye were mycobacterium species like tuberculosis and Mycobacterium leprae or leprosy. So what I did is we looked at the drugs that they were using for these other persister bacteria. And I had used these drugs in residency about 30 years ago when I was treating HIV patients with mycobacterial infections. And one of the drugs that really caught my eye was Dapsone, which is a drug that's been out for a very long time. It's generic, very inexpensive. It's been used to treat everything from malaria to toxoplasmosis to acne to dermatitis herpetiformis seen with gluten and celiac disease and also leprosy. And the thing about the qualities of this drug is it not only is a persister drug, but also it has autoimmune properties. It's been used for Beset syndrome, which is an autoimmune disease. They didn't know how it worked, and I'll tell you in a second some ideas I have about this because I published a paper on it last summer. And then also it hits Babesia, malarial organisms. They use it for malaria. So I thought, well, how interesting, a drug that is a persister drug for slow-growing intracellular bacteria, which is where some of the Lyme bacteria hide. It hits these autoimmune manifestations, and it hits parasitic infections like malaria. So we did a clinical study that we published last year in April of 2016, where we reported the first 100 patients on Dapsone. And what we found is it was statistically significant in improving all of the symptoms except for headaches. It helped fatigue, joint, muscle, and nerve pain, sleep disorders, mood disorders, memory, concentration problems, and it was especially effective in people with Babesia. So we published the study and then went on to do a second study, which was a case history where we used another mycobacterium drug called pyrazinamide, which is used to shorten the course of tuberculosis. And we used this in a patient with Beset's, an autoimmune disease, and found that it was quite effective. So what's new about this book, and the reason I really wrote this book, was to include all of the new science and these persister pulsing protocols that we've developed. And we're now finding that in that 8% of the people that did not get better from the regimens in my first book using the 16-point MSIDS model, probably about 2/3 of the people who have failed all prior protocols are now improving. So it's really quite exciting to have this new data. And I'm really happy to be able to get it out for people. The new book has details about this protocol so you can work with your doctor. It's in the book and in the addendum in the back of the book explaining all the side effects, the dosage, how you use it, so people can take it to their local physician and work with them in a healing partnership.
Wonderful, thank you. And is there a herbal equivalent if doctors, their physicians are unwilling to prescribe?
I mean, what to do if physicians are not willing to prescribe?
Yeah, is there something herbal or alternative that could be considered?
Well, I mean, there are a lot of other drugs out there that are persister drugs. So, for example, if they don't want to prescribe dapsone, the closest drug to dapsone would probably be Bactrim, which is trimethoprim sulfamethoxazole. So Bactrim or Septra double strength is also a persister drug. We do not have a head-to-head study to compare Bactrim versus dapsone, but I would say that definitely there are a grouping of people who will find that if they do regimens, for example, with a tetracycline, with Bactrim or Zithromax and Bactrim, those drug regimens will help with not only Lyme but also Bartonella, because we find Bartonella is sensitive to Bactrim. But we're finding, and again, I put this in the new book, that many of the people who have failed prior protocols, they need multiple intracellular drugs. So even if your doctor will not prescribe dapsone, you may still find that you need triple or quadruple intracellular combos like doxycycline, rifampin, Bactrim versus doxycycline, rifampin, dapsone. And what I reported in my new book, How Can I Get Better, is that Eva Shoppe did culture studies at the University of Haven. We found that within the first 72 hours of using the higher doses of a tetracycline, rifampin, and dapsone, it killed off 50% of the Borrelia that was in biofilms. And the Borrelia in biofilms, these are Borrelia that are dormant. These are the ones that relapse. They're one of the most difficult forms of Borrelia to kill. I used to think that it was just the cystic forms, sometimes called round body forms, cell wall deficient forms, S forms, L forms. We used to think the cystic forms was the major way that Lyme relapsed, but now we know that it's really also the biofilm forms where the biofilms are protecting the bacteria. Those dormant bacteria, they need to be reactivated, and that may be in part how dapsone is having its effect. But it is definitely more effective using rifampin. Eva Shoppe's work found that rifampin opened up biofilms and killed Borrelia by 30%. That was the first time we learned about that. So rifampin is also a tuberculosis leprosy drug, and I now realize that probably the reason we've been having luck with rifampin over the years, or rifampicin, which some people use in Europe, is that it's probably working on biofilms at the same point that it's going inside the cells to kill the bacteria.
That's fascinating, thank you. Anna, we started getting questions in from the group now, and Anna asks, how would you best treat young children with congenital Lyme and co-infections? Would you have a similar approach?
So with children, there are, of course, certain drugs that you can't use. You're not generally going to use quinolone drugs, Cipro, levofloxacin, moxifloxacin. You're not going to use those in children. You're not generally going to use tetracyclines below the age of 8 because of teeth staining. So in the children, most of the time, from what I've seen from Dr. Jones and the pediatric doctors, the regimens you're generally going to be looking at are cephalosporins like Septin, cefuroxime axetil, Omnicef, Ceftinir. You'll be using things like azithromycin with rifampin or rifampicin. Those are probably some of the most common drug regimens that work well for children, and you can use rifampin or rifampicin in children too. So I don't have a large pediatric population, but I would say, and this is going to apply to both children and adults, the real key to to getting people better is you've got to go through the 16-point MSIDS model in my book, because it is literally like people going into a doctor's office with 16 nails in their feet saying, I've got foot pain. You've got to find all the overlapping sources of pain. And what we find in our patient population, whether it's children or whether it's adults, is it's usually Lyme, and you have to treat all the different forms, the cell wall forms using penicillins or cephalosporins, cystic forms using Plaquenil, which again, you're not going to use a lot in children. You'd probably use more grapefruit seed extract as a natural cyst buster, although Flagyl and tinidazole can be used. Intracellular medications, very important to rotate, but it's all individualized. So one person may respond well to a cell wall drug, and another person may not respond at all. So you've got to know the individual wiring of the body. The thing about the MSIDS model is a personalized precision medicine model where everyone's going to be completely different. So some people will have babesia. They may have the day sweats, the night sweats, chills, flushing, air hunger, and cough. And if you don't treat that parasite, they're just not going to get better. Some people have Bartonella. And the problem is the 17 pathogenic species of Bartonella. So just doing a Bartonella henselae may not pick up all the different species. We generally find that a VEGF, vascular endothelial growth factor, can be a blood test that can be helpful. And here in the States, we'll use other testing from like Ed Breischwartz's lab from Galaxy Laboratories or IGeneX, where they do a Bartonella fish test, fluorescent in situ hybridization. So Lyme, Babesia, Bartonella are probably the most common persisters. And we also see persistent mycoplasma. So I'd say regarding persistent bacteria, you're looking at Borrelia, Mycoplasma, Bartonella. There are also other tick-borne infections like tularemia, Q fever that are persisters. Brucella is a persister. And then Babesia, which is a persistent parasite. So you've got to look at all the infections. You've got to look at all the overlapping sources of inflammation. And that could be I'm not getting to sleep at night, where you're getting high levels of interleukin-6. You have mineral deficiencies like zinc, which will cause an increase in inflammation. You're eating the wrong foods. You have leaky gut and food allergies. That can bring on an inflammatory response. You can have mitochondrial dysfunction from these free radical oxidative stress affecting the parts of your cells that make energy. Many people have POTS dysautonomia, where their fatigue, dizziness, palpitations, memory problems are not just requiring antibiotics or herbs, but actually bringing up the blood pressure. Many environmental toxins showing up with heavy metals, mold toxins, detoxification problems. So again, the key is everyone's going to be different. And even in the autistic population, in a young child with autism spectrum disorder, the doctors in Europe are definitely finding antibiotics like Zithromax are helping a certain number. I have some of that research in the publication in the back of the book. We are finding detoxification, heavy metals, change in the microbiome of the gut, propionic acid in certain bacteria with microbiome issues are causing definitely problems now with Lyme and inflammation, as well as autoimmune disease, cardiovascular. So again, the key for getting better, go through the 16-point map. It doesn't matter whether it's congenital, whether it's a young child, an adult. It's always going to be the same, but everyone is going to be different. You've got to look at that individualized MSIDS map and see how many overlapping factors that you yourself suffer from.
That makes a lot of sense. Thank you. And I think that actually links us quite nicely to two questions that have come in that are very similar. One is from Alexandra, and she says, do you believe that people can get better and not necessarily cure, but to be manageable from Lyme disease and co-infections? And Andrew asks, can patients with nerve damage caused by Lyme disease improve with medication?
Well, if I didn't think people could get better, believe me, I wouldn't have spent a year and a half of my life writing this new book. So, the thing is yes, of course they can get better. I've devoted my life, it's 30 years now, seeing over 12,000 people. And I promise you, you can get better. Now, the thing is that, with the protocols, and especially these new protocols, which is the reason I took, so much time. This first book took me 4 years to write. So the second book, we condensed it down and we added all the new science. So like in the first book, I said, we don't know what causes Morgellons. Now we know it's Lyme. In the first book, I said, well, we don't know what causes star eye, which is a rash that looks like bullseye in the Midwest. Now we know it's Borrelia species. So there is a lot of new information in the book, but it is especially the new information on persisters and pulsing, which really drove me to write the book, because we were having such amazing results with people with these new persister protocols that I wrote it. And it's the same with the nerve dysfunction. If you look in my book, you'll see that I updated not only the questionnaire with the scoring, but I updated the part of the book that describes, for example, if you have nerve pain, what are your differential diagnoses? So if you look carefully at the first and the second book, you'll see I did actually add quite a bit in the second book. So, for example, nerve pain, you've got to treat Lyme, but you also have to go after Bartonella. And the problem is you may not be able to find Bartonella, but what we find is the people that have Lyme and have Bartonella and have heavy metals like mercury, lead, arsenic, those all cause nerve pain. or you might have mold toxins causing it, autoimmune problem. You have to look for anti-ganglioside antibodies, anti-myelin antibodies. You may have an autoimmune phenomenon, which is also driving the nerve pain. And some people are immune deficient with CVID, chronic variable immune deficiency. So if you have low immunoglobulins or low subclasses, which happens from Lyme, and you don't use IV immunoglobulins, you're not going to get the nerve pain better, and you're not going to get some of those bad herxes under control. So yes, you can get better from nerve pain. You definitely can get better. And I've seen people on the Dapsone protocol who never have to go on IV medication, where I can avoid an IV Lyme. You do not have to put it in. Dapsone gets very good penetration into the brain. Some people's cognitive symptoms have significantly improved on Dapsone. So I'm really very excited about these new protocols. And again, in the addendum, all the details are there. But again, I would say if your doctor's not willing to do it, substitute Bactrim if you're not sulfur sensitive for the Dapsone, see how it goes. But really, the Dapsone is what's showing really the enormous success. And pyrazinamide, this other mycobacterium drug, we've used it in less patients because of potential liver toxicity, but there are definitely also a grouping of people who have noticed help with it.
Brilliant. Thank you. I think that's also answered another question that came in from Christina around whether you think that it is possible for people with severe cognitive issues to get better from oral antibiotics and not just from IV alone. It sounds as though if you add Dapsone in that you believe that is possible.
Yes, but the thing about it is, for example, some doctors don't use enough tetracycline. So if you're going to use doxycycline, you've got to use 200 milligrams twice a day to get adequate central nervous system penetration. Lower doses of doxy are bacteriostatic. They inhibit the organisms where your immune system has to kill it. Higher doses of doxy are bactericidal. So they have a killing effect, and you'll have a much better penetration up into the brain. But you can combine things like doxycycline with good central nervous system penetration, flagyl or tinidazole with good central nervous system penetration. Dapsone clearly gets up there. So really the key is, yes, you can combine the antibiotics that get up into the CNS. The other thing about, though, the neurocognitive symptoms is the part you've got to really address is detoxification. There are neurotoxins that are getting into people's brains. Quinolinic acid is one of the ones I describe in the book that you do see with Lyme disease. And we know that whether you're talking about autism or Alzheimer's or Lyme, these same inflammatory cytokines, tumor necrosis factor alpha, interleukin-1, IL-6, they're produced by these small cells in the brain called microglial cells. You get it with Alzheimer's, autism, and Lyme. So if you don't lower down the cytokine production of these inflammatory molecules, the neurological symptoms are just not going to get better. And so really, yes, you can do it with orals, but you've also got to detoxify these neurotoxins. Some people, about 70% will tell us on IV glutathione that their brain fog, their headaches, their dizziness, their light and sound sensitivity, their mood disorders, all those, neuropsychiatric symptoms get better just with detoxification. So some people it's glutathione. Some people it's using binders like charcoal, clay, charcoal, cholestyramine, Welchol. You've got to look at the detoxification. That is just as important for some people as using antibiotics, oral or IV, if you've got neurological symptoms.
Yeah, understood. Thank you. And a question that's come in from Emma, and a similar one actually from Barbara, is around whether it's safe to rapidly kill under protocols like this for severely ill people. So one person is bedbound, very, very sensitive to anything and everything that's been taken so far, and the other person, her husband, only has one kidney.
Right, so in someone that's very sensitive, that's very ill, it's usually wiser if you start with doing detoxification protocols. So, for example, when you look up the section in the book on functional medicine and the back of the book, you'll see that generally for someone like this, I'm going to want to work the phase 1 and phase 2 liver pathways to make sure they're functioning efficiently. So things like diindole methane, which is from indole 3-carbinol from broccoli, will affect your phase 1 liver pathways, as well as using natural products like green tea extract, silymarin. You can use phase 2 liver detoxification supplements that drive the glutathione pathway, like N-acetylcysteine, up to 2,400 milligrams a day. alpha-lipoic acid up to 600 milligrams twice a day if you don't have a bad case of hypoglycemia, blood sugar swings. Glutathione can be used at 1 to 2 grams, either oral, liposomal, or IV. Methylation pathways and methylation blocks need to be looked at. And then you want to block NF-kappa B, which is a switch inside the nucleus that turns on these inflammatory molecules. And the way that you do that is by using things like NAC, alpha-lipoic acid, glutathione, antioxidants. There's something inside the cytoplasm of your cells called NRF2 or NRF2. And if you use products like broccoli seed extract, which is a very powerful form of a cruciferous vegetable, this is the strongest nutritional supplement that has ever been shown to increase the phase 2 liver detoxification. So I give people 100 milligrams twice a day or 3 times a day of broccoli seed extract. I might give them high-dose curcumin, green tea extract, and resveratrol. Those 4 supplements all will translocate NRF2 into the nucleus, and it will shut down NF-kappa B from making these inflammatory cytokines. So if you block the production of the cytokines, you open up the detoxification pathways, you use drainage remedies like for the liver, the kidney, and the lymphatics, and getting people on a gentle exercise program with lymphatic massage, and you work, in other words, trying to do everything you can to shut down the inflammation and open up the detox before you start the protocol. That will be very helpful for people that are sick, apart from looking to see if they have overlapping causes of inflammation. So if someone has leaky gut with food allergies or gluten sensitivity, or is not sleeping or a zinc deficiency, you want to get those things fixed because those are going to be overlapping sources of inflammation before you go in and treat with antibiotics or herbs in a very, very sick person.
That makes a lot of sense. I think we'll all be listening back to this about 100 times and rereading your book many times over to take all of this in. Thank you. A question's coming from Beverly about what would you do about resistant insomnia? I know that's a common problem with people in the group.
Right. So the thing about resistant insomnia, like anything, is you have to do a differential diagnosis. What I expanded on in the model in this book, I was a speaker at the Institute for Functional Medicine in San Diego last summer, where I talked about sleep disorders and included, how Lyme affects them. And if you look in the sleep chapter in my book, you'll see there's a whole differential diagnosis of why people can't sleep. So it's the same kind of thing of like you go to the 16-point MSIDS map and you go, what are all the things that might be keeping me sick? Do I have Babesia, Bartonella, low blood pressure with POTS? For the sleep, it's the same thing. You have to figure out, for example, are you taking drugs for ADHD like Vyvanse, which has a very long half-life as a stimulant? Are you drinking coffee too late in the day or tea too late in the day or chocolate, which turns into theobromine? Do you have sleep apnea, which is the reason you're not sleeping, or restless leg syndrome? Are you simply depressed or anxious? Are you getting up in the middle of the night to urinate because there's a bladder issue? So you've got to get to all the sources also for sleep why people may not be sleeping. Now, Lyme is one of really the few diseases that cause delayed sleep-based syndrome where people cannot fall asleep for hours or have hypersomnolence where they might sleep for 16 or 20 hours and can't get out of bed. What we find for the people with sleep disorders, apart from looking for sleep apnea, restless legs, and the things I was discussing, you've got to use drugs, not just the standard sleep drugs like Ambien and Lunesta. You want to also use drugs that will get people into stage 3, stage 4 non-REM sleep, which will get you into that deep dream state. Those are separate drugs like trazodone, Gabatril, which is a seizure drug which has very few side effects and hits GABA receptors in the brain to shut people's brains down. We will use like GABA creams, GABA powders, or pills with Gabatril GABA receptors. We will use things like Flexeril, cyclobenzaprine, which is a muscle relaxant to put them to sleep. There's Xyrem. There's a whole host of different medications that you could use to get people to sleep, but it's not the classical sleep drugs, like even Lyrica, which is a drug used for neuropathy and fibromyalgia. We will use Lyrica because it gets people into stage 3, stage 4 sleep. So we will combine herbs like valerian root, Amantia from the Cowden protocol, melatonin. And the interesting thing about melatonin is it inhibits one of the inflammatory cytokines, Th17, So it not only helps with, phases of sleep, but also inflammation. We'll use Chinese herbs, which we'll use from Dr. Zhang's protocol for getting people to sleep, or Cabernet. There's a lot of natural products that you can get, which you can combine with, regular sleep medications. And those usually we find get people to sleep. But again, you've got to go through that differential in the sleep chapter just to make sure that you don't have any overlapping causes, that it's not Lyme. Because we do find sleep apnea in young, thin women. We do find, restless leg in people where that needs to be treated separately. And even that could just be from magnesium deficiency, where you need to use a lot of magnesium at night, which helps. So it always in medicine goes back to the same thing: do a differential diagnosis, understand the different phases of sleep, and then look at combining medications and natural products, herbal products, to get you to sleep. We find that most of the time that's the most effective way to do it. And then around the menopause, women that have low progesterone will also hit GABA receptors in the brain. So you can use progesterone creams or capsules, pills at bedtime. That also will help women in the perimenopause or menopause to get to sleep.
Brilliant, thank you. We've had Matt and a few others ask about what your thoughts are on bioresonance, Rife, homeopathy, whether they can be useful as part of a treatment protocol, and whether you think there's a possibility of them getting people into remission alone.
So I think definitely these alternative therapies, they do play a role. I mean, the problem I have with Rife machines is there's probably 20 different varieties out there, and people use different frequencies. So, I hear anecdotal stories of some people saying they do get sometimes better. Most of the time what I hear, by the way, is they get Herxheimer reactions. What I did in my new book, there's a section when I talk about functional medicine integrative, I describe, I think, 24 or 25 different natural protocols out there. The ones that we use a little homeopathy, but we find for the really sick patients, homeopathy may not be strong enough for, the most ill. But the people, by the way, who are very sensitive, some of those people will do well with homeopathics. We generally tend to rotate through the Cowden protocol with cat's claw cemento with Bandrol, or Camunda Aquina. We out of the Byron White protocol with AL, a Bart, a Myco, some of his detox protocols. I will use traditional Chinese herbs from Dr. Zhang, Coptis, Hudiana, R5081, Susan McCamish, Beyond Balance protocol. So we generally tend to mix and match a lot of these herbs, including, things like Smilax, Red Root, Bone Set, some of the natural herbal protocols with teasel root, that help but also shut down the Herxheimer reactions. So, my experience has been more with using the herbs, but, we have people coming in on IV ozone, which I don't do, but they get it from other, from other doctors. And some of these oxidative therapies definitely will help certain people with Lyme. You just can't, by the way, do it on dapsone because you'll get a high methemoglobin level. But the oxidative therapies are sometimes helpful. We have people doing magnet therapies with certain people. Joan Randall in the United States has a specific technique. Some people have told me they've had luck with her protocol. Like anything, I think what's necessary is we need good controlled studies to scientifically validate it, because I do hear anecdotal studies all the time, and I do believe they are helpful. I think what physicians need in the future is a good center where a lot of the classical and integrative medicine technique can be used simultaneously, where we can study it. But definitely it varies from person to person. I think a lot of these therapies out there, yes, there is a role for them, but keep in mind with Rife and others, we don't know the long-term effects of putting you in front of an electromagnetic frequency generator. We're already exposed to EMFs. We're already exposed to a lot of environmental toxins. So, I think we don't completely understand what it is to do this on a regular basis. And I think more research does need to be done.
Thank you. What are your thoughts on fungal infections, yeast, that sort of gut problems, in terms of both treatment besides diet, and whether they need to be treated before, after, or in conjunction with Lyme therapy?
I usually use the analogy, for example, if you've got multiple ninjas attacking your house, you want to have a multiple strategy to be able to get each one. I don't personally find that doing them one by one is necessary. I find that when I put together protocols, if someone has Lyme, Babesia, and Bartonella, I want to put together a protocol that's going to help them. And I'll give you a perfect example. A young woman came into my office a couple of years ago. She flew in a wheelchair. Her mother contacted me on Facebook and said, if you don't see my daughter, she's going to die. She's seen 4 neurologists, 4 infectious disease doctors. She's seizing. She can't eat. She can't poop. She's on 480 milligrams of morphine, and she still has pain. And she came up to see me, and I had her fill out the MSIDS questionnaire, which we're now calling, by the way, the HMQ, Horowitz MSIDS questionnaire. We just put it in the scientific literature. We're waiting to hear back about the publication, but we just submitted it. And I gave her the questionnaire, and the first question is, do you have day sweats, night sweats, chills? And she said yes. She's 15 years old. She said, I have drenching night sweats. And I said, well, you probably have babesia. I then looked at the pain, and I said, does your pain migrate? Does it move around your body? She said, yes. How do you know? I said, well, that's classic for Lyme. Lyme causes migratory joint pain, migratory muscle pain, migratory nerve pain. And by the way, we validated that in this new questionnaire, which is going to be published in the literature. I then examined her. I picked up her shirt, and she had stretch marks, which were going perpendicular, that were classic for Bartonella. And then I tried standing her up out of her wheelchair, and her blood pressure, which was 90/60 with a pulse rate of around 90, bottomed out where I couldn't hear the blood pressure, and her heart rate went up over 30 beats per minute. She had POTS dysautonomia. So I treated her Lyme, babesia, Bartonella, and POTS walking out of the office, or I should say in the wheelchair in this case, with doxycycline and rifampin, with Plaquenil for treating the Lyme and Bartonella, Malarone and Artemisia to treat the babesia, and then salt tablets, licorice, and fludrocortisone, Florinef, to treat her POTS. And she came in 1 month later. She flew up again, but this time she wasn't in a wheelchair. She was walking. She had no more seizures. Her bowels were normal. Her pain was completely resolved, and she was off her morphine. And, she felt completely well going out to parties with her friends. But I treated 4 nails in her foot, Lyme, babesia, Bartonella, POTS, all at the same time. And truthfully, I don't know that you can do this separately, because if you just try treating POTS alone or Bartonella alone, but you still have active babesia, it doesn't make any sense to me. There's an easy way to combine these protocols. You can do azithromycin with Bactrim with Malarone, which will hit Lyme, Bartonella, and babesia all at the same time. But of course, it's individualized. So my approach is to do as much as possible at the same time. But as we talked about earlier, if you're very sensitive and you herx a lot, you may want to go slower or open up the detox pathways in these people and kind of work, giving them things like IVIG if they need it, or detox pathway with NAC glutathione. You certainly have to do that in some people, but once we support the detox pathways and try and lower the inflammation by blocking NF-kappa B, we find that we can treat a lot of these things simultaneously, and I think that's really part of the success we have in treating these very, very difficult chronically ill people.
That's very reassuring, as somebody sat right next to where you're talking with migratory pain and a terrible chill at this present time, so thank you. And it leads me quite nicely onto questions around testing. So if somebody's filled in your HMQ questionnaire and it indicates that Lyme and co-infections are likely, and that you might recommend testing, what testing do you recommend? Particular labs, particular tests for Lyme disease and co-infections, and also what are your thoughts on the Ellis spot? Right, so what I did in this new book, How Can I Get Better, is I lumped a lot of the lab tests. You'll see it when you start going through the book in sections. So, for example, with Lyme, what I would suggest in the UK, not that you can't do an ELISA, but it makes a lot more sense to do a C6 ELISA in the UK, because you've got Borrelia abszelii causing acrodermatitis chronicum atropicans and Borrelia guarini causing neuroborreliosis. And the C6 ELISA will pick up those species better than a standard ELISA. So I usually will start with a C6 ELISA with a Western blot, but I use a lab like iGenix because it uses more than one strain. So knowing that there are 100 strains of Borrelia and you're not going to pick up all the European strains on one test, we do find that using a test by iGenix, which uses several strains like the 297, not just the B31, we can get bands on the Western blot that are, show up and they're more specific for Borrelia. So, the game I like to play with people to let them know if they have Lyme, it's called Lyme Bingo, is if you do a Western blot through a good, reliable lab and you have any one of the following numbers,
23, the outer surface protein C, 31, the outer surface protein A, 34, the outer surface protein B, 39, or the 8393 bands. Those are Lyme specific. Now, you can get a 31 band, for example, having mononucleosis or having certain autoimmune illnesses, same thing with a false positive ELISA. But IGeneX does have a test called the Lyme 31 epitope test to find out if it's a true 31 band. The ELISpot I do think is useful with the lymphocyte transformation test. I think it's a good other test you can use in Europe. PCR testing, polymerase chain reaction with DNA, not very easy to pick up these bugs because they don't generally hang out in the bloodstream. They're usually more in the collagen and deep tissues. There are some newer tests on the horizon. The Lyme.blot from IGeneX. There's in fact, TGen, I was just out in Arizona. They're working on a reverse DNA test, an RNA test with a fish for these different species, but that's going to take probably a couple of years at this point. There's the Spiro test, which is being developed through Columbia, which will check for early inflammatory chemokines. So, for example, they found that there are these inflammatory molecules called chemokines that pull your white cells and lymphocytes to the site of the infection. And they're known as CXCL9, CXCL10, and CCL19. These show up before antibody production. So if you came down in the UK with early flu-like symptoms and headaches and you just felt awful with sweats, but your testing was negative because it was too early for antibodies to form, we should have this new test, the Spiro test, available in the very near future. There are also new tests, for example, being developed through George Washington University, where we're looking, for example, at the OspA antigens, the urine antigens, also showing up. So there's a whole host of tests you can use. I can't use the culture test in the U.S. from Advanced Laboratories, which Dr. Borscano helped to develop. But I find that if I just use the ELISA C6 with the Western blot, I can figure out most of the time if people have it, also using my questionnaire and looking at the Borrelia-specific bands. Now, again, when you go to my book, you'll see for Babesia, for example, you need a panel approach. There's not just Babesia microti, but Babesia wall-1 duncani. The immunofluorescent assays are different. If you just check for microti, you won't pick up duncani. We find the Babesia fish test from IGeneX very effective. For the Bartonella, we don't just do titers for henselate, but we might check for Bacilliformis and Quintana. And if you can do Galaxy Labs, you do it. But IGeneX has a BART fish. We can do a VEGF, vascular endothelial growth factor. I lay out, you'll notice in the book, I lay out in the separate sections what tests to do for BART, what tests do you do for Babesia, but you'll see that most of the time it's a panel approach. If you're going to look for an autoimmune problem, you're going to do, for example, an ANA, but you're going to do a double-stranded DNA to look for true lupus. You're going to do a rheumatoid factor, but you're going to do a CCP to check for true rheumatoid arthritis. So you've got to work with your healthcare provider if you've been diagnosed, for example, with an autoimmune disorder, to check to see whether it's a true autoimmune disorder or it's Lyme mimicking an autoimmune illness, which happens, all the time. So really the key is take a look at the book and take a look at each subsection of how do I test for food allergies? How do I test for autoimmune? There's a lot of tests you can do. It doesn't mean you have to do them all, but usually when people come in, I will run, a CBC and a biochem. I'll always check for tick-borne, for Lyme, Ehrlichia anaplasma, Babesia, Bartonella, Q fever, rickettsial infections like Rocky Mountain, tularemia, brucella. These are standard tests I run, on the first visit with autoimmune markers, checking for heavy metals and toxins, sometimes checking for mitochondrial dysfunction with free radical oxidative stress markers like lipid peroxides. So the real key is look at that book, work with your healthcare provider, but it is a panel approach. It's not going to be one or two tests that's going to pick this up. And if you don't pick it up on the first round, and let's say you didn't do an LTT, an ELISpot, if you didn't do it on the first round and your Lyme testing is negative, do it on the second round. And that's really what I describe in detail as a very logical progression of how to do the test. That's what I kind of highlighted in the second book.
I think that logical progression really helps. I think it can be quite overwhelming as a patient new to this to know where to start with testing. So I think that will be an invaluable resource to our members that are new to this. Moving on to a slightly different topic around transmission, Anne has asked what research is being carried out and what research are you already aware of into other routes of transmission, and what's your experience in practice of routes from other vectors, spiders, fleas, lice, horseflies, mosquitoes, etc., and also sexual and congenital transmission.
So congenital transmission is well known, not just for Lyme, but also for relapsing fever Borrelia, which can also cause even a hemorrhage and stroke in women. And that's not just the standard relapsing fever Borrelia hermsii, but Borrelia miyamotoi, which now has spread worldwide. So relapsing fever, Lyme, rickettsia, babesia, Bartonella, these all can be transmitted to a fetus. That's well known. For the blood supply, we know that Lyme can be carried in the blood supply, but yet we don't have real cases of transmission yet, but it's possible for relapsing fever, and it's been published for Babesia, Anaplasma, and Bartonella. So we now know in the United States that 4 out of 1,000 blood transfusions contain babesiosis, and if you don't use Red Cross screened blood, there is a possibility of getting it. Ticks are still the most common vector for getting Lyme. There is a question of sexual transmission. Ray Stricker and Maureen Middleveen have published a couple of studies, but I don't think it's common. They only found a handful of spirochetes in the secretions, whether it was sperm or vaginal secretions, and normally you need much higher levels of bacteria to transmit. Same thing like, for example, with strep throat. If you have 1 or 2 strep, you can't transmit it. It's got to be a large number. And when you look at epidemiological studies on Lyme, it's mainly transmitted in the spring, summer, and fall. And I would imagine in the wintertime, people are still having sexual relations. So I really would expect that although it's possible that it can happen, I don't think it happens very often, unless there might be, for example, open lesions or something where it might be, a source of entry. Bartonella is known that it's mites and it's ticks and it's lice. Spiders have recently come up. So we know that there are multiple transmission sites for Bartonella. Regarding mosquitoes, they found spirochetes in mosquitoes, but it's never been shown to be, as of yet, an effective vector. So that's something that still needs to be determined at this point in time.
Thank you. And I guess leading on from that, if somebody has got chronic Lyme disease and co-infections, I guess there's you wouldn't recommend becoming pregnant while still symptomatic, but once they're in remission, do you think it's safe then to become pregnant, and what would you recommend in terms of treatment during pregnancy?
Yeah, so the thing is we've had over 100 women at this point who've gotten pregnant, and you may have seen my jokes in the book, but many times they write me a letter and thank me, and then I show it to my wife, and she asks, well, how much of a role exactly did you play in this pregnancy? At which point I always point to the baby and say, his nose is nowhere near the size of mine, honey. I really don't think it's likely. That's what you get for marrying a Sicilian jealous wife, but who's, by the way, gotten better after 20 years at this point. Pregnancy, we have women who have had no symptoms and still had miscarriages from Lyme. So you need to understand, even if you're asymptomatic and you did not get treated early on, I always suggest going on a cephalosporin like cefuroxymaxatil, which is completely safe in pregnancy for helping to block the transmission. That being said, we've had a handful of women who gave birth where the amniotic fluid was positive for Lyme, or the placenta, or the babies actually were healthy, but the placenta and amniotic fluid showed Lyme or even mycoplasma. Yet the babies were fine. They were completely well. Azithromycin can be used in pregnancy, but it does not get into the placenta, so it's more for the women. The issue is if you have active Lyme, if you have mild symptoms, you can still get pregnant. You can go on something like cefuroxime and azithromycin and still have a healthy pregnancy. So I don't know that you have to be 100% symptom-free, but what you do have to be careful with is that you don't have an active case of babesiosis. There was a woman that I'll probably write up the case study shortly. She had 4 pregnancies, and 2 of those pregnancies, she relapsed her babesia during the 3rd trimester, and I had to give her clindamycin, Mepron, and Zithromax in the 3rd trimester. If you don't treat a woman and the baby has babesia, they can die from hemolytic anemia. So anyone with day sweats, night sweats, chills, flushing, air hunger they can't explain, a cough, any classic symptoms of babesia, you want to kind of clear up and make sure you don't have active babesia before you go into pregnancy, because it's a lot easier to treat it before getting pregnant than it is during pregnancy. So that would really be my best advice is go on drugs that are safe. As long as you take enough probiotics and stay away from sugar, there shouldn't be problems with yeast. We've rarely had to use IV ceftriaxone, Rocephin, in the first trimester of pregnancy for women who can't hold on to a pregnancy, who've had multiple miscarriages. But definitely the babies are healthy. We have not yet seen a congenital case of Lyme as long as a woman is on the right antibiotics during pregnancy.
That's really reassuring. Thank you. Simone and a couple of others have asked questions about dual diagnoses. So what would you recommend for somebody that tested positive for Lyme and co-infections but have also been diagnosed with ALS, MS, Parkinson's, Alzheimer's, that kind of thing?
So you'll see one of the things I included in my new book about these neurodegenerative disorders is one thing that's come out about ALS, MS, and Alzheimer's is you're now linking it up. Not only to Lyme disease, which has been linked up before in the literature, but also to environmental toxins. So we now know that Alan McDonald's research has shown this before from the Harvard study he did years ago from the NIH McLean Blood Bank, where he found brain biopsies of people with Alzheimer's disease, 7 out of 10 had Borrelia. And Judith McCloskey, who's done wonderful work in Switzerland, has published the same results. But there's research from the University of Pennsylvania Drexel that they're now finding Borrelia in biofilms in the patients with Lyme disease, but they're also finding Helicobacter pylori, which is that spiral-shaped organism like Lyme in the stomach causing ulcers and gastritis. They're finding chlamydia pneumonia. They're finding herpes viruses now in Alzheimer's disease. They're finding pesticides. This was published in the Journal of the American Medical Association back a couple of years ago. So what I highlight in this new book is that 9 out of 16 points on the MSIDS map have now been associated with Alzheimer's. So infections, toxins, hyperinsulinemia, where you might have metabolic syndrome or diabetes with too much insulin, lack of sleep. There's a whole host of things now driving the inflammatory process. In ALS, they discovered environmental toxins that are now being linked to it. I discussed it in my first book, Taking a History. Since this this newest version, they actually published a study showing that the ALS population is showing up with a lot of environmental toxins. Same thing with MS, where you know that you can get mercury that will have retrograde transport into your brain and demyelinate the nerves. So, the real key for any of these diseases is go back to the 16-point MSIDS model, look at multiple infections, environmental toxins, anything that is driving the inflammatory response, autoimmunity. You've got to look at all of it because no matter what you name the disease, whether you call it autism or ALS or Alzheimer's or MS or any of these diseases, the one thing they have in common with the central nervous system manifestations is inflammation. And that's been shown in all of these different diseases that there's microglial activation in the brain. The small glial cells are the ones that turn on the inflammatory process that are damaging the nerve cells and the brain cells. But now I think it's a question of going after biofilms as well as treating the infections, getting rid of the environmental toxins. And certainly we've seen people who've used IVIG and other things to help with some of these autoimmune manifestations. The thing about ALS is 90% of the cases that present are still what I would call true ALS, which is genetic causes with superoxide dismutase, environmental toxins. It's not, due to Lyme. Only about 10% will respond to treatments of infectious diseases. But some of these people with ALS and MS, those are the ones you want to start looking at stem cell therapies to start replacing some of the damaged nerve cells. So that's kind of the approach we've taken where we've had some benefit in people with these very severe neurological disorders.
Thank you. I think that leads me quite nicely on to 2 other questions. One was from Lee, and that was asking, does stem cell treatment work for Lyme? I know you mentioned it there for ALS, but what are your thoughts on it for Lyme and co-infections?
I don't have really as much experience with Lyme and co-infections. I don't think it's going to play a big role except in people that have damage someplace in their body. Now, most of the people I see, I can reverse the vast majority of symptoms. The only people that, might need stem cells, for example, if you have bone-on-bone arthritis in your knees, they know that stem cell therapy is not embryonic, but even your own stem cells from your hip or from your abdominal fat can be used with stem cells injections and platelet-rich plasma. They can be used to basically help bone-on-bone arthritis. That's been shown. But I think unless it's damage, I don't think at this point it's necessary for Lyme. I think it's more the neurological diseases like MS, ALS, where we may not have easy answers for some of the people, and they're definitely, and especially in ALS, where there's damage to the motor neuron cells where you have to regenerate more motor neurons. I think it's more important in those type of diseases.
Okay, thank you for that. I think that leads, Caroline asked, and I think you probably answered it there quite well, but just in case you have anything to add, do you believe there can be permanent brain damage in severe cases, or any permanent damage for that matter?
It's not that there can't be permanent damage, but in my experience of 30 years of doing this, the vast majority of the symptoms are reversible. And again, in the first book, maybe 8% didn't get better. Ever since I started using these persistor protocols with dapsone, 2/3 of those patients that failed prior therapy are now improving. The problem with dapsone is 1/3 of the people can't tolerate the drug. I describe it in the book as do no harm. H stands for Herxheimer reactions, A stands for anemia, R stands for rashes, and M stands for methemoglobinemia. There are side effects of the dapsone protocol, but you can minimize it by using high doses of folic acid, large amounts of glutathione, but about 1/3 of the people still can't tolerate the drug and may have to use a different persistor drug. But it's not that there's never damage, but I do see significant turnaround in the vast majority of people where I don't really believe there's a lot of damage unless you're really talking about the joints. Now, the thing about people who end up with Alzheimer's disease, I do believe, and I'm not trying to say that if you get Lyme, you're going to get Alzheimer's. It's just that it is showing up in the medical literature as one of the possible potential associations with Alzheimer's, and again, not just Lyme. Viruses like herpes viruses, chlamydia pneumonia, even Porphyromonas gingivalis, which is a bacteria underneath the plaque on your teeth. And the plaque on your teeth is a biofilm. That's why you have to get it taken off to get to it. They're showing that bacteria is showing up in the brains of people with Alzheimer's. So I think, damage from that point, if you have amyloid production in the brain from infections and toxins, and they've shown that if you put brain cells in culture and you give them pesticides, they form amyloid plaque and tau protein. So I do think that most of it's reversible, but of course, if you get to a stage where you have a lot of amyloid production, that might be a different story. Now, they are looking at things to actually reverse the amyloid plaque. And believe it or not, CBD and some of the derivatives are actually being shown to maybe have some help. But I think that's the only place I would say, apart from people with degenerative joint disorders where they're bone on bones, or they have a neuropathy where the nerves have really been damaged and they need IVIG, those would really be the cases where I see you need more intensive therapy. The rest of the people, the vast majority, 95, 99% of the time, it's reversible.
Thank you. That's really reassuring, I'm sure, to many people listening. You mentioned there around toxins, and you've mentioned about radiation and EMFs as well. Have you any recommendations in terms of avoidance and the necessity to avoid them?
Well, the thing about EMFs is not everybody is sensitive. I actually wear things around my neck to protect against EMFs. I have an EMF protector on my computer right now where I'm speaking to you. I think people need to be careful because the one part that I did put in the new book is on cell phone radiation. You should never be putting your phone up to your ear. They are definitely now associating this with brain cancer, with glioblastoma. There's absolutely no doubt about it. It's shown up in the mouse model when they did it. We've seen it in people, in the United States with this. So that's, I think, the most common form where you can really see it. But the problem is there are people with EMF sensitivity where it makes their leaky gut worse. So when you're talking about leaky gut and healing the gut, which is another form of inflammation and autoimmune disease, people who are exposed to EMFs and mercury and certain toxins have shown that they don't heal the gut as well. So I think even if you're not feeling the effects, we now know that, mercury and these toxins are definitely bad for the body. Mold is showing up in people, pesticides. These are all foreign-based estrogens. They have carcinogenic effects. So considering that 1 out of 3 women and 1 out of 2 men have a chance of cancer in their lifetime, I think doing a regular detoxification program is, at this point, we don't have scientific proof that you're going to live longer and not get cancer or Alzheimer's. But when you look at the literature of what these environmental toxins are doing, I think it's reasonable at this point in time to be taking things, eating organic, pesticide-free, no GMO, eating very clean, exercising, detoxing with infrared saunas, take things that upregulate your glutathione pathway and making sure your methylation pathways are working, using high doses of broccoli seed compounds. These are very reasonable things, I think, even for people that are not sick, just because of what these toxins have been associated in medicine. So I think we need more prospective studies, but I think definitely we need to be looking at the toxins. And in my patients, the environmental toxins combined with the infections are probably the main reasons why they're staying ill, apart from hormone dysregulation, where the inflammatory cytokines shut down your pituitary, POTS dysautonomia that some of the doctors don't check for, leaky gut and food allergies, sleep. I mean, those are like the top 5 or 6 big things that are keeping my patients ill.
Indeed, and they're certainly not going to harm anyone by doing those detoxifications on a regular basis, so it sounds very sensible advice. A few questions back, you mentioned autism when we were talking about dual diagnoses. We've had a question in from David about how you would treat a 3-year-old autistic child with congenital Lyme and EBV. Would you use antibiotics and or herbals as well as gut support? And is there anything else you have to comment on that?
Right. So the thing is I am not an autism expert. I don't regularly see children. I've really only treated a handful of them over the years. People like Ken Bach would probably be able to answer that question a lot better. But what I do know, what I can tell you, is when I've gone to the autism conferences and they've invited me as a speaker, and this was years ago, they were already using a lot of the things that I have on the MSIDS map without my ever having even discussed it with them or seen them. I generally, if you speak to the doctors that do autism, they will tell you it's a broad range of things of getting the microbiome in order, decreasing Clostridium and different species that cause propionic acid in the gut. There are certain children who've done probiotic enemas using the right type of bacteria that have reversed autism spectrum. There was a study published from Harvard University several years ago on broccoli seed extract, 300 milligrams of sulforaphane glucosinolate, decreasing the brain symptoms in autism in about 2/3 of the kids. So what I've seen from the literature and speaking to colleagues, but not personal experience, is that antibiotics, I know the Chronomid doctors in France have used Zithromax. I've seen it work in autistic populations when I'm there in France speaking to them about it. So it seems like it's very similar to the MSIDS model. It's antibiotics, it's co-infections, it's BART, it's microbiome of the gut, it's mercury, it's leaky gut, it's food allergies, it's gluten, it's detoxification problems, it's EMFs, it's all of it that you see on the MSIDS model when applied to the autistic population. From what I've seen and speaking to doctors, I think it's the answer, but I can't say herbs or antibiotics because it's individualized. If a child, for example, has candida or is very sensitive to antibiotics, it might be better to start with herbs. But again, it's going to be individualized and personalized. And that's really the key of the 16-point MSIDS model, is every person is going to be different. Of
course, that makes a lot of sense. John's asked about autoimmunity and how you deal with anything that's been triggered by Lyme, such as autoimmune encephalitis or other autoimmune conditions.
Right. So repeat it. So how would I treat it exactly with autoimmune?
How would you deal with autoimmune conditions such as autoimmune encephalitis that have been triggered by Lyme and co-infections?
Right. So for the autoimmune encephalitis, there's a panel, and I describe it in this new book, in the Cunningham panel, where you look for anti-dopaminergic antibodies. There's about 5 antibodies they look at, which have been associated at this point with autoimmune encephalopathy. These people generally need IVIG. So there are 3 classes of people that will do well with IV immunoglobulins. These are the people with chronic variable immune deficiency with low immunoglobulins or subclasses, the people that have small fiber neuropathy where they have a positive biopsy, and the people who have, for example, a positive Cunningham panel with autoimmune markers against the brain. Those are the people who usually do well with IVIG. But that being said, the Lyme and the co-infections cause autoimmune reactions. So again, Lyme will cause autoimmune reactions. Mercury will cause autoimmune reactions. We now know that small particle pollution, BPA, a lot of environmental toxins, asbestos, is causing autoimmune reactions. So again, if you're going to look at the most common forms of autoimmunity, you've got to look at tick-borne infections with environmental toxins as well as the autoimmune phenomenon that accompany it. So I would say, again, you go to the MSIDS model, but it is IVIG and treating infections and toxins that will probably have the greatest effect with detoxification.
Of course. Thank you. Two questions that kind of link together here. One is from Julia around the main reason you see for people relapsing once they stop treatment, and the other from Caroline around whether you have a recommended protocol once someone is in remission.
So, I mean, the reason people relapse is a lot of times we find that depending on the load of the bacteria, how long people have been sick, how their immune system is functioning, the kind of stress they're under. I mean, we find that any stress, if your adrenals are not working properly, you can get into a fight with your significant other, not sleep for a couple of days, get into a car accident, whatever. Any stress, big stress, if your adrenals aren't working, the Lyme is going to relapse. That's a very common one we see in people. And probably the most common one, actually, apart from like I got a viral infection and my body just can't fight several infections at once. So, you've got to make sure the hormones are balanced, the adrenals there. But a lot of times when people have treated Lyme, they may not have treated with these new persister protocols or treated biofilms. So what I would say is if you've, used standard protocols with like cefuroxime and Zithromax, and you've done standard protocols which help but aren't curative, you've really got to start looking at persister protocols, biofilms. I'm not sure still, by the way, the role of the pulsing. I describe it in the book. The research from Kim Lewis suggested it could work, but his study was mainly in early Lyme where they're active. We don't really know in later disease, although some people have told me it has worked. It's a small group of people. But I think mainly where you want to go with relapses is look at your hormones, look at your adrenals, make sure they're in good shape, that there's no other infections, and then look at using the persister protocols and biofilm protocols, which I have found to be effective in the people that have failed classical protocols.
Thank you. Gemma has got a similar question that links to that, and it's around somebody that's been a more acute case. So infected 5 months ago, had 2.5 months of antibiotics at the beginning. Most of the symptoms have gone, however, now started to have symptoms such as fatigue. What would you recommend? Starting to treat again?
Well, again, it depends, because fatigue is the one symptom that probably has the most differential diagnoses. Again, if you open up my book and you look at the chapter that has that, you'll see that there's probably 30, 40, 50 things that can cause fatigue. The issue with it, again, has to be the most common causes of fatigue would be adrenal, being low. A lot of people have food allergies with hypoglycemia, where they swing their blood sugars. They have ongoing POTS dysautonomia, where their blood pressure is not high enough. But, if you come back and you go, I have good and bad days, my symptoms are coming and going, I have migratory joint pain, migratory nerve pain, migratory muscle pain, my symptoms are worse around my menstrual cycle, before, during, after, that's classic for Lyme. Or I have day sweats, night sweats, chills, flushing coming back. That's suggestive of babesia. So, or maybe you have mitochondrial dysfunction. The part of the body making energy has not been cleared. You need to do a mitochondrial support. There are multiple overlapping factors, and again, it's really looking at the symptoms and how many points on the MSITS map you've treated. So fatigue alone it's a little bit difficult to say, but I would say if it's months later and it's only fatigue without like a lot of overlapping Lyme symptoms, you should be looking at hormones and other things that still might be causing it.
Thank you. Thank you. And if someone's following your protocol and using the mixture of antibiotics and the pulsed and the persister drugs, how long would you expect before they should respond to that protocol? How long would they give it before they tried something new or sought to add something to their protocol?
About 80% of the time we'll see a response in the first month of the protocol. Rarely we will go for 2 months in case people are having herxes and we're not sure that when they come out of the herx they may feel better. We generally do not go longer than 2 months on a protocol. So even if I'm using a persister drug, like let's say I started off with doxycycline, rifampin, dapsone, with some plaquenil and some biofilm busters like stevia, lauricidin, biocidin, serapeptase. Let's say people are not responding to that protocol. You may have people that are sensitive to tetracyclines and they do nothing but herx. You could always move the tetracycline to azithromycin and use azithromycin, rifampin, and dapsone and find that's the answer. Or they're having day sweats, night sweats, and chills, and that you add Malarone and Artemisia or Cryptolepis to the doxyrifampin and dapsone because your babesia is active. Or you may need a fourth intracellular drug. So, for example, you might need a quinolone. You might need doxyrifampin, dapsone, and Levaquin, or doxyrifampin, dapsone, and azithromycin. So really what it depends on is I don't usually go past 30 days, 60 maximum. The key is always going back to the MSIDs, finding out what is the overlapping causes of the symptoms. Because, again, you may not be detoxifying well with your herxes, and once you come out of the herx, you're great. Or the POTS may be a problem, or the adrenals are a problem. So if you're not responding, even in that time frame, you still have to go back to the 16-point MSIDs model. And again, you may need to go back and keep checking the co-infection. Sometimes the Bartonella is negative early on, and all of a sudden a titer turns positive, or a VGF turns positive. This is what happened in the second article that I published last summer on the woman with an autoimmune disease, Behçet's. She had failed almost 20 years of rheumatologists using, prednisone and drugs that suppress the immune system. And she had these big ulcerations on her tongue, different parts of her body, a lot of inflammation. And she took pyrazinamide, which is a tuberculosis mycobacterium drug, and it cleared up the ulcers. And all of a sudden, when I was using dapsone, rifampin, doxy, her Bartonella activated. And she had a case of tularemia, that the titers were low, and it went from 1 to 20 to 1 to 320 with a herpes virus 6 reactivation. So you can have bacteria and viruses that are hiding in your body that can relapse, and I think dapsone is probably bringing them out in some cases. So you need to redo the testing from time to time when people get worse to find out if you've actually reactivated the infections, and then you go in and you change the protocol. But definitely 30 to 60 days, rotate the protocols. Everybody's wiring is different. You want to know, with a history, how do you respond to doxy? How do you respond to another tetracycline like Minnow? Do you like Biaxin, clarithromycin better than azithromycin? Do you like ruxithromycin better than those? Everyone is individualized, and you've got to use the history of how people herx, what they like, what they herx with. You've got to use that information when you're putting together protocols. That's why it's completely individualized.
Yeah, of course. And do you always expect symptoms to worsen before they improve for patients to herx if they're treating? Do you think they should push through hard herxes? At what point do you know to back off?
So, it varies for people. There are people that, will first get better and then they herx, or first herx and then get better. We generally, see it's one or the other, and we don't generally see people that just get better without herxes. I mean, that's highly unusual. So the thing about pushing through a herx is if you're taking, for example, 2,000 milligrams of liposomal glutathione twice a day with Alka-Seltzer Gold, and you're doing drainage remedies and saunas and lymphatic drainage and everything you can do, you're taking the BLT formula, Red Root, Boneset, Smilax, Sarsaparilla, a low-dose naltrexone, curcumin, resveratrol, green tea, broccoli seed. I mean, you're throwing the kitchen sink at people to shut down the Herxheimers and the inflammatory response, and it still doesn't shut down. Then you have to sometimes stop the antibiotics, give people a break. What we found with dapsone is 4 days off dapsone, generally the herxes would resolve, and then sometimes we can put them back on the same dosage and they'd actually be fine. But it varied. Some people, it took them 7 days before the herx resolved. So using a pulse therapy where, you ask people to push as far as they can without making it intolerable, because once you get to the other side of a herx, right, you sometimes are better. But the key is you can have what I call a good herx or a bad herx. A bad herx would be you're functioning at 50% of normal, you're on a protocol, you go down to 20%, you stop the protocol, and you're back to where you started at 50%. That is a bad herx. That means you did not lower the load of the bacteria or of the parasites at all. But if you go to 20% from 50, and when you come out of the herx you're at 70, that's a good herx. That means you managed to lower down the load of the bugs in the body. And then you're at a new higher level of functioning. So that's kind of how I determine if you keep having bad herxes, I'm not going to leave you on that protocol. I'm going to go back to your chart, and I'm going to see what did you positively respond to, what have you herxed with, what drugs have you not done, have I checked all the overlapping points on the MSIDs model that might be keeping you sick. That's kind of how I figure it out.
Great. Is there anything you'd recommend for a herx other than detoxing to get through it?
Well, the regimen I've been telling you about with Red Root, Boneset, Smilax, Sarsaparilla, that can be effective. Sarsaparilla or Smilax is an herb that's known to, it's published in the literature, to decrease Herxheimer reactions. So, that is very, very useful for people. Low-dose naltrexone is very useful for a large number of people, apart from detox and lymphatic drainage. And again, what I talked about earlier, with things that translocate NRF2 into the nucleus to block NF-kappa B, like high-dose broccoli seed, you need to try all these things. But again, it doesn't work. And some people, with low immunoglobulins, they won't stop herxing until you give them IVIG. I have people that their herxes are remarkably better when they went on IV immunoglobulin therapies. What I think is kind of sad is I don't think the insurance companies that are paying for these very expensive therapies realize that Lyme disease is the major reason why most of these people are coming down with chronic variable immune deficiency, needing immunoglobulin therapy, which is quite expensive. Much easier to do tick prevention and get it early than to deal with all the long-term manifestations.
Of course, of course. You've mentioned IVIG a few times now, and Karen's asked, using it for nerve damage, can nerve damage be ascertained without doing painful nerve conduction tests?
Well, the thing is an EMG, a nerve conduction study, and a biopsy is really one of the best ways of telling. You could also do things like auditory evoked potential, visual evoked potential. Those are the kind of non-invasive tests they use when they're checking for multiple sclerosis and nerve damage. But usually those are the ones really you're looking at, apart from checking autoantibodies against the nerves, like anti-myelin, anti-ganglioside antibodies. But it is true that nerve conduction and biopsies is probably one of the best ways to be able to tell. And of course, doctors like Dr. Younger, Dr. Katz, neurologists in the U.S., they'll do a whole host of tests looking at POTS dysautonomia to figure out if you have autonomic nerve dysfunction. So some of those tests that I describe under the POTS chapter, those can also be done to see if there is an autonomic neuropathy.
Wonderful, thank you. You mentioned LDN when we were talking then as well. In what cases do you think LDN is useful for patients?
Truthfully, I think it's useful in most cases. My wife is still on it after years, and she's had a very positive response. You have the LDN Trust and Foundation in the UK. Someone just actually came over and filmed me on Lyme disease and the use of LDN. I find LDN to really be a great drug. It's even been shown up in the medical literature to help with certain resistant forms of cancer with IV alpha-lipoic acid. There was a study by Bert Berkson published through the National Cancer Institute using it for that. So the thing about LDN is LDN will shut down the microglial activation in the brain that we've been talking about. It shifts from a Th2 to a 2H1. It helps your immune system a bit with intracellular infections. It lowers inflammatory cytokines. They published it on MS, on fibromyalgia, on Crohn's disease, so other autoimmune diseases. I've easily used it in over 1,000 Lyme patients. It's a very, very useful drug. You just can't use it in people who need narcotics. And if you have any of the sleep disruption on LDN, taking it at night, you would use it first thing in the morning. We still find that it could be effective in some using it in the morning. But definitely it's worth a trial in the majority of people because knocking down the inflammatory response is kind of the name of the game in getting people better with this disease.
Thank you. Andrew asked a quick question about whether chemotherapy is ever appropriate for Lyme.
Dr. Zhang had discussed in some of his papers using certain chemotherapeutic agents which would cause DNA adducts, which looks like it would kill Lyme. I don't think anybody is at the stage right now where they're so desperate. They're going to take chemotherapeutic agents, which are used for like non-Hodgkin's lymphoma and some of these drugs to be able to treat Lyme. That would be excessive at this point in time. You have to be careful with chemotherapy, of course, because it can affect your immune system. Mm-hmm. So, no, we're not there yet. I don't think we're anywhere near at this point having to use those type of drugs. There's many more studies that are going to be needed to do, looking at some of the drugs that Dr. Zhang published from Hopkins on these cancer drugs, like anthracyclines, that are used in other diseases. But there is no clinical indication at this point in time for using it.
Thank you. Rick asked, how much emphasis do you place on genetic polymorphisms and epigenetic expressions and addressing them during the course of treatment, for example, MTFR, CBS, COMT?
So, most of the people who come to see me have MTHFR mutations. I personally don't actually find it to play a large role. But certainly in a small percentage of patients, the methylation pathways are blocked and they can't use methylcobalamin. They may need hydroxycobalamin and other forms. Regarding the other genetic variations like COMT and all the rest, yes, there are clearly patients. There's GenoMind, there's different ones you can check, and I think some of the people with the psychiatric manifestations may do very well with some of these who metabolize psychiatric drugs in different ways. But I still think that you can work around it. You can work the detox pathways in a lot of these people to get them better. So yes, it plays a role, but at least in my practice, I wouldn't say that it's one of the biggest nails in the foot that's keeping people ill. But regarding epigenetics, what I think is important to know is that a lot of these infections and a lot of environmental toxins are transmitted epigenetically from mothers to future generations. So, I think we need to really talk also about how to protect the future generations of our world with tick-borne diseases and environmental toxins, because a lot of these do cause problems with, the epigenetics. So I advise most people, methylation is one of the best ways of helping with epigenetics, but things like resveratrol, broccoli seed extract, curcumin, zinc, there are many other epigenetic modifiers, and I take most of these myself because there are genes in the body, like the P53 gene that turns on cancer. If you can, genetically modify some of these genes and shut them off using methylation, using broccoli seed, it may be possible to start to change our destiny. So I think from the point of view of what epigenetics does, it's important, but definitely we're going to need longer prospective studies to look at this to see the full effect.
Brilliant, thank you. And just before we get to the final question, we've had quite a few comments coming in that are basically saying the same thing or a very similar thing. And so Bob, Joanne and May and a few others have basically said, thank you, Dr. Horowitz, you're my hero. Would you ever consider opening a clinic in Europe or meeting with the UK health organisations such as the NHS? So many people here in the UK need your help.
So I don't know if you know, but I actually met Tim Brooks from the UK Health Department for your NHS. I met him at the LDA conference in Rhode Island back a couple of years, and I introduced myself, gave him my card, we emailed, and I actually was on a conference call with Tim Brooks, probably it was a year and a half ago, where I spoke to him and I sent him a large scientific document with all of the scientific research showing that the testing is terrible, and that it doesn't pick up all the species, and there's co-infections, and then it can persist. I gave him all the scientific data. I have absolutely no idea what he did, but I offered to Tim. I said to him, he said we were going to have some type of a panel in the UK. I said I'd be happy to fly over and participate. I never heard back. And I was in contact at one point with other people in the UK. I won't describe them. You probably know who they are. They're very well-known people in the UK who have gotten Lyme disease, an entire family. I've been in touch with them at points in time to try and help with opening up a clinic, but that did not pan out. So what I'm doing right now is I am looking at a state in the United States. I don't want to give you too much information because it's not yet determined if it's going to happen, but it's looking very, very promising. I will probably be opening up the first MSIDS clinic for chronic diseases in another state through a university where I may be getting an assistant professorship where I will be teaching medical students before they come out of med school. We'll be doing studies through the university to prove what I already know is true and publishing in the literature. And I spoke to a very large foundation, not the one in the UK, but another foundation who I'm in contact with and I'll be speaking with later today about opening up clinics in other countries. So I have been having that conversation, but nothing fruitful has emerged at this point. Now, the thing is I can only be in one place at one time. So I'm going to try and get a professorship to teach med students. Hopefully, we're developing an app, eventually a digital app on phones and computers that you and your physicians can use. But we need several $1 million to raise to be able to do this digital app, which will help to kind of get standard protocols in place and get all the information uploaded to the cloud so we can get better data on people with Lyme. And the 21st Century Cure Act was passed through Congress where they're giving $100 million for Lyme disease research. And I was recently elected to serve in the Congressional Committee for Lyme in the United States. So there is a lot happening. I'm happy to help your NHS, but somebody's got to be open-minded and reach out. Regarding clinics, I'm always happy to help open clinics and work with other governments. I've been a consultant for the Chinese government, for the Australian government. I've been a consultant for the UK through Tim Brooks, the Belgian government, the French government. I've been doing this for many years. The problem is because of the politics of this disease, that it's not just a medical disease, a political one. You have factions that are very strong, including in the UK, with your infectious disease doctors, who are believing the IDSA guidelines, which, as you know, are 10 years old, outdated science. I've heard behind the scenes that they're going to come out with guidelines that are probably even going to be worse because they're holding up their own reputations, which is all based on, old science. And clearly there are conflicts of interest with testing that some of the members have where they make money on tests. So the politics of this disease, you really need a scientific committee where the NHS, your doctors, other, specialists in the field, health insurance people, sociologists, everybody's got to come to the table, patient advocates, take a look at the hard science, see what it is, take a look at the research that I've been doing, do some prospective studies with things like Dapsone. We're hopefully going to have a prospective study by the end of the year. I think all of these things need to be done, but you've got to have compassion for sick and suffering patients and say, look, we know that what we're doing is not working. We may not be sure why it's not working, but it's not working. Let's get a scientific committee and look at both sides. And when I spoke to Tim Brooks about this, he said the factions in the UK were very strong and that it had to go step by step, looking at this. But what you can do, as your group is I'm happy to participate, whether through a Skype call or eventually, getting to Europe. I won't have time on the European trip. I'll be at ILADS in Paris in May. I'll then be in Amsterdam at the Royal Theatre that Sunday. I think it's May 19th or something at the Royal Theatre. About 1,000 people are going to be there with an interview on Lyme. And then I'm doing a Lyme talk in Venice for the Italian group. So I'm doing kind of a step-by-step European tour, but I can only take up so much time from the office. But if you invite me, in the future when I have more time to the UK to do this and meet with the NHS, believe me, you have my full support here. It's just that there's got to be an open-mindedness on the part of the NHS to say, we're going to look at the science, we're going to work with Dr. Horowitz, we're going to look at all the new research out of Johns Hopkins and the rest to help the people in the UK, and get people from both sides of the camp at that meeting so it can be discussed in a collegial fashion. I think that's the only way you're going to really kind of get things to move forward.
That's fantastic to hear. Thank you. Your support's just so appreciated. We'll definitely be in touch about that. And it's really exciting to hear about your hopefully very close plans in the US. That would equally be at the moment, if we have to go abroad for treatment, obviously the ultimate goal is to have things here in the UK, but getting better is the primary concern. So where people can afford it, that's a great option. So finally, really final question before we wrap up. What would you say to a patient who feels like there's no way out and they're ready to give up?
I would say, please, please, please do not give up. Giving up would be the worst thing that you can do. The only reason I took a year and a half out of my incredibly busy life to write a book that sells for $11 on Amazon in the United States, I could have made more money working in McDonald's than I did writing this book. I don't write books to make money. I write them because I have something important to say to help the world populations. There are protocols in this book, and you'll notice when you read it, details of everything I do, the Dapsone protocol, dosing, the supplements that I use, the companies I use for the supplements. I've given way more details in this book, and the reason I did it is because when my first book came out, Why Can I Get Better?, people said, hey, we love your book, but we still have a problem understanding exactly what to do. And then I started seeing all this new research working for people with persisters and biofilm. And as I said, about 2/3 of the people who failed other protocols are getting help with these persister protocols. You cannot give up. There is hope for people. The 16-point MSIDS model definitely helps. The key is you've just got to get to a doctor that's going to work with you on it. And look, you have to advocate in the UK with the NHS. If you have people that are ready to give up and say, we can't do this anymore. If you don't do something, we're going to give up and we're not going to be around any longer. You need to tell them how seriously you're sick and put the burden of responsibility on your leaders in your country that they have to do something about this. And as I said, Tim Brooks got the full document a year and a half on the testing and on the persistence. It's not like no one has ever communicated with the NHS about, I did my part a year and a half ago about what this is. You cannot give up. I beg of people, please don't do it. It would be a waste of your life. I have people who've been very ill that when they get better, I say to them, the way you're going to pay it forward, you're now going to med school or a PA program, and you're going to go out and you're going to help people with it. You can pay it forward when you're better and help other people with this. That is really the best advice I could give people, is have self-compassion on yourself for your suffering. Do not give up. Speak to God's Spirit, however it is you connect with the universe, and ask for the strength that you need to be able to do this. But just know I am there. I am in the background looking for answers. And I've seen tremendous research and help come in the last couple of years, these protocols that are definitely helping people. So really there is hope. And that would really be the best message I could give to people.
Thank you so much. Lyme Disease UK, and I'm sure all of our members share exactly the same goal. And we've recently been in touch with all of our MPs. We've been writing to them, and as a result, there is a big event which we'll drop you an email and give you details about, which seems to be culminating in a group of our government getting together to try and help us. So we'll give you the details of that, and we'd love to welcome you to an event in the future when you do have time to come to Europe, or like you say, over Skype. Thank you so much for your time. It's been absolutely wonderful to speak with you today, and there's been so much information here. For any members who haven't already bought Dr. Horowitz's book, it is on the comment directly above this video. You can click through to the link and buy that now. When I looked yesterday, it was sold out on Amazon UK directly, but you could still get it through the other people selling through Amazon. And I'm sure it will come back into stock very quickly. Have you got anything you'd like to finish with to wrap up, Dr. Horowitz?
No, just thank you so much. It's great that you're getting together and speaking together and supporting each other with this. And just know, if you keep your advocacy up, don't give up in speaking to your politicians. The way we're making progress in the United States is, I really did not want to get involved in politics years ago. And I will tell you, I'm deeply involved at this point, and now I'll be serving on a congressional committee. You've got to get involved. You've got to stay involved. You've got to constantly call and email and write your people in the parliament to let them know about the severity, because this is not only affecting people's health, it's affecting the economy. Someone with Lyme disease, they've shown in the U.S., it's $20,000 a year when you catch it late, and it's $400 if you catch it early. They've got to do better prevention practices. They've got to stop the denial of what this disease is doing, and let them know through compassion and good science they can make a difference. So definitely keep up your advocacy work and keep up all the good work that you're doing.
That's brilliant. Thank you so much. We've got over 6,000 members here, which I know in comparison to the US probably isn't a huge amount, but it's still a large number here to keep that pressure up. And equally, those who've got a massive amount from your information today. We're really grateful as well that you've agreed to answer some written question and answers to go on our website, which will give us, our members, an opportunity to learn more from you. And hopefully everybody who hasn't done so already will buy your book. So thank you so much. I'll wrap up now, but we really appreciate your time.
Okay, thank you, and blessings to everybody. I wish you just the best of health.
Thank you so much. Have a good day. Bye-bye.
Thank you. Bye-bye.